Good morning, everybody. So the topic on which I'm going to speak today is on osteoradionecrosis. It's a very common complication that we encounter in patients following head and neck cancer treatment. So the osteoradionecrosis, it is a dire complication which follows a radiation therapy following a head and neck cancer. So induced osteonecrosis or osteoradionecrosis, which we popularly call them. It ranges from a small asymptomatic bone exposures that remain stable for months to years, and it can heal with conservative management, to sometimes severe necrosis with pathological fracture, which necessitates a surgical intervention and reconstruction. It is defined by multiple authors, but one of the pioneer work that has been done by Schwartz and Kagan defined it as an exposed irradiated bone through a wound in the overlying skin or mucosa. It persists without healing for 3 to 6 months in the absence of any recurrent or residual tumor. The most important thing is that the exposed bone must occur in the absence of a tumor recurrence or a tumor necrosis during radiation therapy or a metastatic disease. The incidence of this condition in the mandible is high. It ranges as low as 2.6% to sometimes 15%. The mean time from completion of radiation therapy to the development of osteoradionecrosis as reported in the literature. In the development of osteoradionecrosis as reported in the literature, it ranges from 22 to 47 months. Now let us briefly describe about the anatomy and what makes mandible as one of the most prone bone for osteoradionecrosis. Although mandible is affected by osteoradionecrosis more frequently, however, there are literature or case reports of osteoradionecrosis happening in other bones of the maxillofacial skeleton. It could include maxilla, zygoma, hyoid bone, etc. So if you look into the anatomy of mandible, the mandible is supplied mainly by the facial artery, as we can see with that arrow mark, as well as it is also supplied by the internal alveolar artery, which supplies mainly the teeth as well as the bone, the periosteum and the bone. In the mandible, the buccal cortical plate in the region of the premolar and the molar, as well as the retromolar regions, are mainly thick, and they are very vulnerable sites for osteoradionecrosis. This vulnerability is because that the bone in that region is denser. They have a higher mineral content, and thus they have a propensity for absorbing higher radiation dosage. That makes that area of the bone, as I can show you by the arrow, in the region of the premolar, molar, as well as in the retromolar area, as highly vulnerable to cause an osteoradionecrosis in that area. Besides that, the mandible is also more likely to be in the field of radiation, mainly for the tumors involving the oral cavity as well as the oropharynx or oropharyngeal carcinoma, where one of the treatment modality is a chemoradiation therapy. This region of the mandible is one of the areas which is planned within the radiation field, and that causes a higher chances of causing osteoradionecrosis in the mandible. The pathophysiology of osteoradionecrosis has always been a controversial topic. When it was initially described in 1922 by Rigord, it was an early experimental model where it was shown that osteoradionecrosis was showing an evidence of bacteria in the tissue, which is affected by the disease. Then microscopically, the author found out that there were some changes which included the loss of an osteocytes and osteoblasts and the filling of that bony cavity with inflammatory cells. However, based on that theory, Mayer defined in 1970 that there is a triad in the pathophysiology of osteoadrenocrosis. He said that it could be due to radiation. After radiation, trauma in that area leads into the infection that causes the bone to cause osteoradionecrosis. The trauma could be due to any cause. It could be due to tooth removal. And following the trauma in that region, it gives an access of oral bacteria to enter the underlying bone. And then the infection could rapidly progress because the radiated bone has lost its resistance to the bacterial infection. So once radiation is given to the bone and then a trauma happens, this infection causes something called as a radiation osteomyelitis. However, in 1983, with one of the pioneer randomized controlled trials done by Robert Marks, he challenged this theory based on the observation that the osteoradionecrosis did not show any clinical signs of infection, and it neither progressed to sepsis in the same way as an osteomyelitis does. In the study that he conducted on 26 patients, he found out that the bacteria was only present on the surface of the bone and not inside the necrotic area, indicating that the microorganisms play a very minor role in the pathophysiology of osteoradionecrosis. Also, Marx found out that almost 35% of his cases could not be correlated with any episode of trauma, including extraction of teeth. When Marx found out the specimens microscopically, he found out that the tissue showed fibrosis of the mucosa, skin, and the marrow spaces. It causes hyalinization and thrombosis of the vessels with the loss of osteocytes and osteoblasts with decreased vascularity of the connective tissue. Based on this, Marx proposed a four-part sequence in the pathophysiology of osteoradionecrosis as radiation, followed by formation of a hypoxic, hypovascular, hypocellular tissue. The tissue then breaks down whereby there is a collagen lysis and cellular death. It exceeds the synthesis and cellular replication. And as a result, it forms a chronic non-healing wound in which energy, oxygen, and structural precursor demands excess supply. So the major driving force in the Marx pathophysiology was hypoxia. And this was the explanation which formed the cornerstone for using hyperbaric oxygen in the treatment of osteoradionecrosis. Then recent advances in the cellular and microbiology have allowed for the development of a new theory in the pathogenesis of osteoradionecrosis. It is known as a radiation-induced fibroatrophic theory. The radiation-induced fibroatrophic theory suggests that the key event in the progression of this condition is the activation and a deregulation of fibroblastic activity that leads to atrophic tissue within a previously radiated area. The hypothesis focused on a defective radiated bone and the imbalance between the tissue synthesis and the degradation of the tissue, divided into three distinct phases: the pre-fibrotic phase, the continuative organized phase, and the late fibrotic phase. So if we look into the pre-fibrotic phase, so once radiation causes injury to the endothelial cells, it causes an acute inflammatory response in that area. This endothelial cell injury results in the release of cytokines that trigger an acute inflammatory response, and it results in a further release of reactive oxygen species or ROS. In the continuity phase, the in the continuity phase, the ROS release cytokines such as a tumor necrosis factors, plasma-derived growth factor, or the interleukins 1, 4, and 6, which results in an abnormal fibroblastic activity, causing a disorganization of the extracellular matrix. Once this progresses to something called as a fibroatrophic phase, there is an attempted tissue remodeling that takes place with the formation of a fragile healed tissue. And this tissue is vulnerable to reactivated inflammation in the event of any local injury that could be even for extraction of teeth. All this results into an hypocellular bone and a reduced bone matrix formation, which is compensated by fibrosis. Based on this theory, the new treatment regimens, which are targeting the reactive oxygen species and radiation-induced fibrosis, have been developed that I will be discussing in the management section. So how do we classify this condition? So there has been numerous classifications in the literature that has been given, from Coffin's to Schwartz and Kagan's classification. I have divided this classification into two parts. Most of the classifications of osteoradionecrosis are based on clinical and radiological findings. However, one of the extensive studies that has been done by Schwartz and Kagan in 2002, he staged this osteoradionecrosis into a stage 1, stage 2, and stage 3. The stage 2 and stage 3 has been further subdivided based on the disease progression. So in the stage 1, the author believed that there is a superficial involvement of the condition, which involves only the cortical bone. There is minimal soft tissue ulceration. So based on a stage 1, most of the conditions can be treated by conservative management according to the authors. When the disease progresses to a stage 2, there is a localized involvement of the mandible, including the medullary bone, which is found to be necrotic. And in stage 2B, the soft tissue, it is the same as stage 2A. However, the soft tissue shows a necrosis. The surrounding soft tissue shows necrosis in that condition. In stage 3, there is a diffuse involvement of the mandible, which even includes the lower border, and there is a presence of pathological fracture in this condition. And in stage 3B, it is a similar condition with the presence of a soft tissue necrosis and orocutaneous fistula. The only classification that was based on the response of an hyperbaric oxygen therapy was a Mark's classification, where he classified it into 3 stages as stage 1, 2, and 3. In stage 1, there is an exposed alveolar bone without any pathological fracture, and according to him, it responds to an HBO therapy. Whereas in stage 2, the disease does not respond to HBO therapy, and it, besides giving HBO therapy, Marx's study also requires to be involving sequestrectomy and saucerization of the mandible. And in stage 3, there is a full thickness bone damage, including a pathological fracture, which usually requires a composite resection and a reconstruction with the free tissue. Yeah. Coming to the diagnosis of this condition, we diagnose this condition based on the history of previous radiation therapy in the patient, as well as on the clinical features. We also need to see whether the affected site in which we see the condition has been within the radiation treatment area. Most of the time, the patient usually gives a history of a dental extractions or any sort of a surgery in that area. However, I would like to stress that there has been a case of there is a good percentage of patients comes with osteoradionecrosis without any precipitating trauma. The clinical symptoms in this condition can include from pain, bad breath, trismus, difficulties in chewing, swallowing, and speech. There are areas of ulceration or necrosis of the skin or mucosa besides presence of a necrotic bone. So osteoradionecrosis is a result of an impaired wound healing, and it is not an infection like an osteomyelitis. But we should also consider that the bone may become secondarily infected, as in most of the cases that we come across. The possibility of recurrence of cancer must be excluded by performing an incisional biopsy before we come to the diagnosis of osteoradionecrosis. Coming to the imaging modalities that we usually utilize for this condition, it could range from anything from panoramic imaging to even a bone scan. On panoramic imaging, we usually find out the areas of inhomogeneous lytic areas, as we can see in the arrows, interspersed with zones of increased radio density. And in the CT scan, most of the time, it is a good modality, imaging modality to distinguish between the bone destruction related to the osteoradionecrosis as well as associated with the tumor recurrences. MRIs also show some altered bone marrow signal intensity in the mandibular parts of osteoradionecrosis. In the MRI, it usually presents as an abnormal homogeneous low marrow signal intensity on a T1 weighted image with an increased signal intensity on T2 weighted images can be seen. The importance of a CT scan or an MRI as compared to any other modalities is because both of them have higher chances of delineating the soft tissue around the bone, which gives us a better picture whether it is a disease recurrence or it is due to the osteoradionecrosis as a condition. And if the patient presents with an MRI and there is a presence of an abnormal findings in the distant or in the contralateral side to the site of the primary tumor with a long interval of approximately 2 years between the primary tumor treatment and onset of symptoms, it is one of the condition that we can say that can narrow down to the diagnosis of osteoradionecrosis and not a tumor recurrence. Coming to the risk factors that is associated with this condition, there has been several studies that has been done. One of them has been extensively done by O's, Q&O study, where the author has found out the numerous risk factors that increases the chances of this condition. It could be the location of the primary tumor, where the patient is coming with the tongue or the floor of the mouth, or in the region of the alveolar ridge, retromolar, trigone, or tonsil, has a chances of giving surgical treatment followed by radiation therapy. And since discussed previously that the bony thickness in that area is higher in the mandible, the chances that those patients will come back with osteoarthritis is higher. The second is about the stage of the disease. In the study by O, it has been found that the patients with a higher stage of stage 3, stage 4 has approximately 3 times higher chances of developing an osteoarthritis compared to the initial stages. One of the reasons behind that could be that most of the time the advanced stages requires a multimodality therapy besides surgery, and so we also include radiation therapy or chemoradiation in such patients, and that increases the chances or the risk of causing such a condition. The dosage of radiation has also been found out to be a factor that increases the chances of osteoarthritis. With a dosage of greater than 60 gray, has a higher chances as compared to any dosage of less than 50 grays. Prior surgery for a primary tumor, especially mandibulectomies or mandibulotomy or marginal mandibulectomy, all these conditions increases the chances of an osteoarthritis. If we look into the study, I have shown that in that study, the primary radiation therapy with or without chemotherapy and the time until the occurrence of osteoarthritis shows a significant chances of causing an osteoarthritis in such group of patients in that study. Similarly, oral hygiene, a poor oral hygiene in the patient or the patient who has been utilizing tobacco as one of the habits during the radiation therapy or following the radiation therapy, increased consumption of alcohol in those patients increases the chances of osteoarthritis. How do we manage this condition? So the management, as most of the studies have shown, that conservative management is the in the initial stages works well for this condition. So in terms of the conservative management, we need to avoid the irritants such as consumption of tobacco, alcohol, or if there is any ill-fitting danger in that area that needs to be removed by the patient. The physician visits that involves a local debridement with antiseptic solutions, including chlorhexidine, and simple management, which involves a gentle removal of sequestra, is all that is required in the initial stages. As I said, that most of the conditions are secondarily infected with uh, with microorganisms. So systemic antibiotics does play a role for episodes of acute infection. Also, patients present with pain in these conditions and analgesics and anti-inflammatories are prescribed when it is necessary. If there is any presence of any plates or screws or any hardwares or any foreign objects that which can contribute to this condition, that needs to be removed. In one of the early studies that was done by Wong for the conservative management, the author found out that the initial stages, when treated by simple conservative management, approximately 70% of his patients showed the resolution of this condition. So, if the initial stages presents with an initial stage of stage one, where there is a little bit of sequestrum present over there, all we require is to give a conservative management and wound debridement as well as an antibiotic coverage that can pretty much take care of this condition. The hyperbaric therapy, as we very popularly know for the management of this condition, is used in the treatment of osteoradionecrosis in a variety of clinical situations. One of the early proponents for giving an hyperbaric oxygen therapy was Robert Marks, who believed that um, if the patients are being given a hyperbaric oxygen therapy, patients breathe approximately 100% of oxygen at an increased pressure of 2 to 3 atmospheres. This increase in the tissue oxygen pressure leading to augmented endothelial cell and fibroblast proliferation. So in the long term, it stimulates collagen synthesis, matrix deposition, angiogenesis, and epithelialization, which in turn promotes wound healing. Additionally, the increased oxygen tension also acts as a bactericidal and a bacteriostatic agent. However, the main contraindications for utilizing hyperbaric oxygen therapy is optic neuritis as well as pulmonary disease. This condition, this treatment therapy is also not without any complications. So sometimes the patients present with eustachian tube dysfunction or a middle ear barotrauma, seizures and decompression sickness following an hyperbaric oxygen therapy. Previously, it has been postulated that hyperbaric oxygen therapy can also stimulate some malignant growth cells in that region. However, there has been no literature that supports this condition, and it should not be a concern for the prescribing physician to give a hyperbaric oxygen therapy for advanced conditions. I have tabulated all the studies which has been done in the past about the giving hyperbaric oxygen therapy for this condition. As we can see, most of the studies has been retrospective that has been done. And if you look into the conclusion section, most of the patients, in spite of having a small number of patients taken in the studies, most of the patients have their osteoradionecrosis got resolved just by the management of an hyperbaric oxygen therapy. However, there has been one as a clinical trial that has been conducted by Anand from the French group that was a prospective multi-center randomized double-blind placebo-controlled trial. This is the only randomized controlled trial which did not, or the ORN96 study, that did not find the efficacy of an hyperbaric oxygen therapy in osteoradionecrosis. In this condition, the author has recruited two groups of patients. One where the patients were giving hyperbaric oxygen therapy of 30 dyes pre-operatively at 2.4 absolute atmosphere for 90 minutes, or a placebo which usually consists of 19% of oxygen and 81% of nitrogen, with an additional 10 dyes was given post-operatively if the patient requires any surgical intervention. Once the author has found out this, has seen the patients after 1 year of the follow-up, They found out that only 19% of the patient had recovered in the HBO arm as compared to 32% in the placebo arm. This trial had to be stopped before the complete recruitment because the authors could not find any differences between giving of a hyperbaric oxygen therapy as compared to that giving a placebo in this condition. So they concluded that the patients did not benefit with the hyperbaric oxygen therapy with overt mandibular osteoradionecrosis. However, this study came out with several critics as well. Because in this randomized controlled trials, the authors excluded the patients with more advanced osteoradionecrosis, as well as those with the extension of osteoradionecrosis to the inferior border of the mandible or the patients with a pathological fracture. So they were excluded from the study. In addition, one of the outcomes in the study was the need for a surgical resection. Although many studies, including the MAPSA study, used hyperbaric oxygen therapy in coordination with surgery as a combined therapy. Therefore, it was claimed that the need for surgery does not necessarily indicate a treatment failure, as has been proposed by this study. Ultrasound is also one of the treatment modality that has been utilized for the management of this condition. The rationale for using ultrasound was due to its successful management in the healing of ischemic varicose ulcers as well as a fracture non-unions. It has been shown that ultrasound increases angiogenesis and it stimulates collagen and bone production. And that was the reason why this ultrasound was also been considered as one of the treatment modality for osteoradionecrosis. In the study published by Harris in 1992, he proposed that 40 to 50 uh, sessions of ultrasound for 10 minutes shows a complete healing of this condition. But in that study, most of the conditions were in the initial stages. However, since the study was done on a very small group of patients and a long-term follow-up was not seen, that is why the treatment modality has not come into the literature as compared to that of the other treatment modalities. Pentoclo, as we know, is a new adjunctive treatment in the osteoarthritis. The pentoclo is an abbreviation for pentoxifylline, tocopherol, and chlorhydrinate combination. So this treatment protocol has come back to us because of the radiation-induced fibrosis theory, as I just discussed in the pathophysiology. This combination, it targets the radiation-induced bone fibrosis and it stimulates the osteogenesis via the antioxidant pathway. So if we break down this therapy, pentoxifylline, it is a methylxanthine group of drug that exerts an anti-tumor necrosis factor alpha effect. It causes vasodilation and it inhibits the inflammatory reactions. Tocopherol, which is a vitamin E, it scavenges the reactive oxygen species generated during oxidative stress. These two drugs, pentoxifylline and tocopherol, they work synergistically as a potent antifibrotic agent. Chlordronate is a bisphosphonate group of drugs. It inhibits the osteoclastic bone destruction and osteolysis. In one of the randomized trial that has been done on a phase 2 clinical trial by Delanian, 54 patients were taken with refractory osteoradionecrosis and were given a treatment of pentoxifylline, vitamin E, and chlor- sorry, and chlordronate was given to those patients. The patients were given a daily dosage of pentoxifylline, which is 800 milligram per every day. Vitamin E was given at 1000 international units, and chlordronate was given at 1600 milligram per day from Monday to Friday. All the 54 patients in this study had a complete recovery over a median period of 9 months. So the authors believe that this is a treatment modality that does play an important part in the management of this condition. However, there is no study that has confirmed the efficacy of this drug in a long term. Surgery is one of the last resort that we usually do for this condition. The indications to treat surgically for an osteoradionecrosis involves a stage 3, where there is an advanced disease which involves the whole of the mandible, including a pathological fracture in that condition, involvement of the osteoradionecrosis to the inferior border of the mandible, patients presenting with a pathological fracture, and patients where there is a failed conservative management. So in surgery, we usually involve the resection of all the involved necrotic bone and soft tissue, and then we reconstruct it mainly with the help of microvascular reconstruction, either in terms of the bone or even a soft tissue reconstruction can be done. The resection for this condition is continued until we come across a healthy bleeding bone at the margin. And after resection reconstruction, with the help of osseous or osteocutaneous microvascular free tissue transfer can be done. So how do we prevent this condition? The NCCN guidelines does speak about the dental care in most of the patients following the treatment of osteoradionecrosis. So the criteria for the extraction of the teeth before the radiation therapy, it involves a moderate to an advanced periodontal disease, presence of an extensive periapical lesions of the root, extensive tooth decay, partially impacted or incompletely erupted teeth. However, if a tooth is totally impacted inside the bone, we don't need to treat it. We don't need to take out those teeth. Residual root tips not fully covered by bone or showing a radiolucency preoperatively are the teeth that needs to be treated first. Dental extraction should be performed as much atraumatically with careful tissue handling, with alveolotomy, and once the extraction is done, a primary wound closure should be done. At least an interval of 2 to 3 weeks of a healing time between the extraction of the teeth and the onset of radiation therapy is recommended. Patients are to be advised to be brushing their teeth with a high fluoride toothpaste, and also the use of an intensity modulated radiation therapy and IMRT is one of the ways to prevent this condition. So concluding on this topic, we know that osteoradionecrosis can be a devastating complication of radiation therapy after the treatment of head and neck cancer. The predisposing factors are clearly evident. However, there is a debate on how best to define it and to classify this disease process. There is a controversy regarding the best protocol of treatment, particularly the use of an hyperbaric oxygen therapy. And new therapies focus on molecular biological agents to prevent and treat osteoradionecrosis is found to be fruitful. However, the long-term studies are still pending. Thank you.
It was well presented. So, what would you give your guidelines for us in our current management? When are we to foresee that this may happen? Because you're saying it has to be prevented, picked up at stage 1.
So first thing is that we have to look into the oral cavity per se and not only into the disease. If there is any presence of decayed teeth or the teeth that is non-restorative or the oral hygiene of the patient is poor, we have to first do the oral prophylaxis, remove of the teeth before we treat the patient. Secondly, this is also important, especially for higher stage diseases or the patients which will require radiation therapy. So the treatment should not be done after we treat the primary disease. The treatment should be done once the patient presents to us, so that we chalk out that what all the conditions that needs to be treated, and we need to do a dental rehabilitation on the patient, and then take the patient. The purpose is not in like not coming the condition not to happen, but to reduce the morbidity of the patient in case that happens. Because it is not only in terms of the radiation therapy, but there are multifactorial conditions that can cause osteoradionecrosis. So we are trying to reduce the risk factors in that condition so that the healing happens well. And if the patient presents in the follow-up period, especially once the patient presents immediately after the second or third month after radiation therapy, we cannot just jump into the conclusion that it is an osteoradionecrosis. We have to first look into the condition, because the mean period of an osteoradionecrosis happening following radiation therapy is approximately 24 months. So it is almost 2 years. So we'll have to first see if the disease has come back or not. We need to do the biopsies. It could be a secondary infection. We need to treat with an antibiotic coverage. And accordingly, if that doesn't heal, then we'll have to move on with the conservative management, or we'll have to give some drug therapies like petroclose.
I think we are seeing more and more of these osteoradionecrosis because of the intensity of radiation. During our fellowship, we used to give about 54 grays post-op. Now it's gone up to 60 grays. They were never giving above 60 grays with cobalt therapy. And now they're giving 66 to 70 grays with upfront radiation, nasopharynx, oropharynx. So we are in a situation where if you are salvaging these patients following radiation, uh, that bone is now becoming unstable, and it is a potential site for osteoradionecrosis. So whenever we are doing salvage, we need to see that the bone is taken care of in and protect. So then you need to use more vascularized tissue for reconstruction. Do not rely on secondary healing. See to it that you are using the instrumentation without more trauma. When you mention the vascularity, the middle part of the mandible, the jaw, the body of the mandible also gets blood supply from the periosteum. It's not just the inferior artery. So whenever we are doing resections and we are doing with power saws and all, we have to see that the thermal damage is reduced and the stripping of the periosteum is avoided. So some care has to be taken when you are doing the surgery so that we can avoid elevating the entire periosteum and see to it that we use good powered instruments with good, thermal protection. So irrigation has to be done properly. The saws have to be sharp and avoid doing, fractures. I've seen time and again when we do marginal mandibulectomy, uh, the, the cuts are not done in a boat shape manner. It's cut straight. And that leads to possibility of fractures. So if we have a devitalized bone, the chances of fracture are higher.
Mainly we see this in marginal mandibulectomy cases where we lift periosteum on both sides and then the patient are given radiation in view of either bone involvement or the neck nodes. In this case, the mandible is mainly devascularized.
And we used to see when we used to use a skin graft. Many times we used to use skin graft over the bone. We didn't have free flaps at that time and we were not covering it adequately. So in those patients, we saw higher rates of osteoarthritis. So now we are using more of vascularized tissue, right? And I'm sure it will reduce over time, but more care has to be taken when we do this.
And so when we take the cuts, it should be clean and any projecting bone or something which is irregular, that needs to be drilled out. That is the main site where the blood supply will be less, those irregular margins and the struts of bone which are projecting out. So those needs to be removed before we put any flap.
I have seen many patients where we have done marginal mandible and we used to use drills earlier and they make holes and then connect it with Gately saw. And many of them came back with uh, multiple sinuses. And that was possibly because what you're saying that the bone at that point where we have taken the cuts has chipped out and has formed a nidus from an infection and has caused sinus formation. So over time we have learned that after you're done marginal, you need to smoothen out the edges, but still avoid thermal damage. When we use drills and all, we don't irrigate as much. So that discipline has to be there. That your irrigation is perfect.
One question is coming to my mind that if by the time this is diagnosed, it usually is 2 years, like 24 months is what
No. The action happens 2 to 5 years. It takes so long for the bone to get revitalized.
The osteonecrosis happens immediately, but
No, it doesn't happen immediately. It's an ongoing process. So you don't have the bone dying or the osteoclast dying immediately. It's a process that happens over time where there is a reduction in blood supply, then there's a fibrotic development of the tissue. Thereafter, the bone undergoes devascularization and then dies.
So roughly over a period of year or 2 years.
Many years. We used to say 4 5 years. He's saying it's 24 months. We used to not see so earlier. We used to say around 4 to 5 years before the osteoradionecrosis sets in.
So on the follow-up, is there any symptoms that the patient presents with, like pain or some weakness in the movement? Anything like that happens that can be a sign to catch it so that whatever intervention like oxygen therapy.
So that is what. So usually the patient presents with pain in that area, or like Christmas. Okay, there can be some sort of an infection, sinuses and all coming out. So since we are treating a cancer patient, we have to look into the condition. We have to see the history of the patient, whether the patient has undergone radiation or not, whether that part of the mandible was involved in the radiation field or not. And it is always better to do a biopsy because it needs to be clear that it is not a disease recurrence before we come to the diagnosis of an osteoradionecrosis. So it is a diagnosis based on exclusions. It is not a diagnosis based on extremity. And 2 years is a mean period of most of the study. It progresses, the chances gets higher as and when the number of years advances.
You have not mentioned about role of antibiotics. We just saw pentochlorine being used, but
So the thing is that initially it was said to be due to infection. So then, but most of the studies said that it is secondarily infected and bacteria is not the causative organism for that. So it is a secondary infection that happens in us. It is otherwise it's a problem with the wound. So if a patient comes over there and we suspect that there can be secondary infection, we can start with the course of antibiotics. But that is not going to resolve the condition according to most of the studies that they say.
because some of our practices wherein we give the low dose and long term antibiotics like doxycycline,
Yeah.
then maybe we should avoid.
No, sir, because doxycycline also has one another property besides antibiotic, or it is a fibrotic causing it. So we need something to heal, cause the wound healing or fibrosis. So doxy has a role in that as well. So doxy for for dental treatment also, we usually give doxycycline in 100 mg that causes a fibrosis. So it is also an added modality besides an antibiotic coverage.
So when we give start doxycycline and pentoxypyrin, how often do we call the patient and when can we stop it?
So if you see the pentochlor trial, that has gone till 9 months. So you have to start with a regimen. Usually we give it for like 2 months, and we have to see if the patient shows signs of improvement. We are not going to stop it. We're going to go at least for 6 to 9 months, and then if it resolves is well good. If it improves and you feel that there is a little bit of a sinus or like there is some sequestration present, it could be like conservatively you can manage it. That can also be done. Yes, sir.
Follow up, is it necessary or to do an imaging or only symptomatically?
So imaging will not improve immediately. So if you see most of the imaging modalities that they say, including bone scans, the improvement in the bone regeneration will not be very conspicuous in the immediate soon after the treatment. So it takes a long time. So if you keep doing imaging modalities, it is not going to show any signs of improvement. So we should look into the patient as a whole. If the patient is showing signs of improvement, then you can do an imaging modality once every 3 or 6 months. But it needs not to be done in regular intervals.
The very idea that you're doing an imaging is to understand if there is a fracture. So if the bone is intact, then you really don't need to repeat the imaging. Unless the patient has developed further symptoms wherein now you're suspecting that there might be a sequestration. The whole idea of doing an imaging was if there is a fractured mandible or you have operated the mandible, you want to know whether now there is some bone which is getting sequestered. So one of the treatment plans is to do conservative management and then do a intraoral bone or sequestrectomy. And only if it progresses, then you will do a resection. So my take on the imaging is I will do it once in 6 months, once you have diagnosed it. The initial imaging would be done to identify if there is a fracture or if there is any bone instability. If there is no instability, no fracture, then every 6 months I will do it in order to understand if there is a progression. So we'll do it for a period of 2 years, every 6 months.
So in many patients, one point is that the precipitating factor is the screw and plates, which the for the fibular reconstruction which is being used. So if there is not good vascularity cover over the screw and plate, those tend to be exposed and repeated infections take place, which causes the osteoradionecrosis. So in those cases, we might have to go ahead with plate removal as one of the therapeutic options.
Sir, I'm meant to decide which patient needs hypertrophic toxicity. Which patient should we give tablet, which patient should we give HBOT?
We put as a protocol, Marx's protocol.
So the Marx's protocol is like you do a treatment. If you look into his trial, he has done treatment and he has also given HBOT therapy before as well as after the treatment. So when announced that study, the randomized control trial, which found out that it is not effective giving hyperbaric oxygen, the biggest criticism that the paper came across is that they said that they have done surgical therapy besides giving HPOT therapy, which is not wrong because Marx's study also did the same thing. So it can be a treatment modality, but like I said, that if you find that you need to do a sequestrectomy in that patient, you have to go back and do that sequestrectomy besides giving hyperbaric oxygen therapy.
So first would be medical and in the middle.
Conservative management. If it is in the stage 1, stage 2, early stage 2, involving only the medullary bone. But if it comes up to the pathological fracture or it involves the whole of the length of the mandible, there is a presence of a orocutaneous fistula, then it is better to go with the surgical therapy.
So the whole concept is the fibrosis atrophy. Here, wherein you want to prevent that fibrosis, you want to increase fibrosis and prevent atrophy. So if you have a patient who you are suspecting is now transiting to an ORL, you would first have to give a conservative therapy. There are those who don't believe in HbO2 and there are those who believe. So those of us who give hypobaric oxygen would start with hypobaric oxygen because you have to increase the blood flow, you increase and give a chance for the body to heal before doing any surgical intervention. Your surgical intervention has to be very conservative. Please do not go ahead and take a skin incision and elevate a flap because that's going to damage you more. And it's a disaster going in and operated and radiate, previously irradiated tissue. So you're not going to gain anything. You will land up with a much bigger problem because then the tissue is not going to heal. So try and give hyperbaric oxygen therapy and or medical line of therapy first. And then once the patient is settling down, you might want to consider if there is a need for a surgical intervention. Usually surgical intervention should be last. And unless you are convinced that this will help, please don't. So many times we might want to just remove the bone because the patient having pain. If you are going ahead, you have to use vascularized reconstruction. So the problem is not of just that bone, it is about providing blood supply which is of adequate quality for reconstruction. So many times you'll resect the dead bone, but land up with a bigger problem because now you can't reconstruct. So think of now using pedicle reconstruction rather than microvascular. Because in those patients you will need something, a fresh tissue, but which doesn't require anastomosis at that stage. And we have to ensure that we don't leave behind any exposed bones before radiation. So before the patient goes for radiation, if you see that there has been any bone exposed, that has to be covered before the radiation starts. all our practices should be geared towards providing a dental hygiene and bone cover before radiation starts. Once the radiation has happened, we can't do it. So use our dental hygienist. We have a dental hygienist who will be able to provide this clean cleanliness, counsel the patient, because you can do it only once, but patient has to do it daily. So a dental counseling, hygiene counseling, restoration of dead tissue, all that has to be done before we initiate. Ideally before surgery.
And it has also been shown that patients presenting with poor oral hygiene have higher chances, at least a fourfold odds in having this condition than a patient who is maintaining the oral hygiene.
That does suggest that bacterial might play a bit of a role in, because oral hygiene might be associated mainly with the bacterial exposure, right?
Bacteria is there, but it's more so with revitalizing the patient, vascularity of the patient. So the bacteria cause infection, and that infection causes damage to the mucosa, and that causes the damage to the periosteum. And that is what causes the bone damage. So we have to prevent the bone from getting infected and damaged by the action of the bacteria and local action on the mucosa and vascular. Any comments?
Sometimes the diagnosis is only difficult. Patient is severe Christmas post-traumatic post-surgery take away. So the diagnosis is the PET scan. So they both the uptake EMR and the recurrence cases. And sometimes it is very difficult to get the biopsy tissue. So in that cases, the diagnosis becomes like the, because any other modality like the panoramic imaging and all that not showing any resolution at that much. Right? So that situation becomes little bit. But the clinician becomes very difficult sometimes know how to take the vision of the bone. So you want to take the biopsy from the foot or something. So clinical difference from the
Mandible and larynx, both of these areas are fraught with oral issue. Please do not go ahead and do biopsy, because the punch biopsy creates more of trauma. It devascularizes and exposes bone, both of which are harmful. So it is better that we initiate a thought process wherein you want to judge whether this patient will merit salvage or not. So you are suspecting recurrence. Now, can you actually salvage it? What kind of salvage you want to do?
because sometimes the plastic surgeon wants to remove that dead bone, but we have to see whether the patient is having any recurrence at the second time.
If you're going to have a recurrence at the site, what is the stage of your recurrence? Is this recurrence stage a T4 and you cannot radiate, then what are you going to gain? In most of the situations, you might end up giving conservative management as a trial basis. If you give a trial of medical line of therapy and the patient improves, you might benefit, because at that point that salvage may not help the patient. So if at all you want to confirm, please use imaging modalities, CT guided biopsies and all, which will be more diagnostic, give a diagnostic yield without causing a problem. So infratemporal fossa, residual mandibles at the condyle, coronoid process. That's where we are seeing suspect disease or osteoradionecrosis. We are seeing on the thyroid cartilage. So in these two situations, please do not go ahead and go bypass. Do a CT guided so that the mucosa is